thank you so much for everyone joining today. I think we can get started. My name is Ashley Reid. I'm the founder and CEO of a company called Wellist. We work with healthcare partners to connect patients to support, whether it's transportation or meal delivery or behavioral health resources, and have spent a lot of the last year really working in testing and now vaccine to make sure that patients and families have what they need at this very vulnerable time. I am so delighted to be joined with an incredible panel of experts to really share their perspectives on what are our opportunities as it relates to health vaccine access, addressing vaccine hesitancy, and improving health equity on that journey. So I'm going to ask everyone to introduce themselves, and I'm going to start by handing it over to Abner to give us an overview, both personally and then more importantly, the important work your organization's doing.
Sure. So thanks for that, Ashley. My name is Abner Mason, and I'm founder and CEO of a company called ConsejoSano, which means healthy advice in Spanish. We are a patient engagement and patient navigation company headquartered in Los Angeles, but we work across the country. What we're primarily focused on is trying to bridge the gap between our health system, which was really designed for traditional English speakers, and actually works best for traditional English speakers who are higher income. And it really doesn't do a good job of serving the country that we've become, which includes a significant percentage of people who are culturally and linguistically not traditional English speakers, and also a significant number of people who are lower income. And so we're using technology to understand who people are at a cultural level, and then use that understanding to engage them and to connect them with healthcare at the right time and the right place.
Great, thanks. Rachel, will you go next?
Absolutely. Thanks for having me today, Ashley and team. It's great to be here with all of you. My name is Rachel Wilson. I serve as the Chief Operating Officer for CIC Health. CIC Health is a company that was founded this summer in response to the need to rapidly expand access to testing services for COVID across the nation. We were founded with the belief that there really was lab testing capacity that could make fast, frequent, low cost, rapid turnaround time testing available to more people so that we could get employees back to work, students and teachers back to school, and all of us back to our recreational activities. We've enabled through our partnerships about a little over 1 million tests to date across 14 states with about 300 different clients, 35 public collection sites, and we recently made the move into mass vaccination services, and we're delivering those services today at Gillette Stadium, Fenway Park, in a community athletic center right in the Boston area. And we have just hit our 175,000 vaccinations administered. So we're really excited about that. So thank you.
Thanks so much. So going from that to testing on the ground, Kelly, do you want to give us an overview of your work?
Sure. Hi, my name is Kelly Orlando, and again, I am so privileged and very excited to be a part of this wonderful panel and this opportunity. I am an executive director in a health system based in the Boston area of Massachusetts. It's called Beth Lahey Health. I'm an executive director, and for purposes of this conversation, I'll be talking about or referencing our experience at a comprehensive health center located right outside of the Boston area that has been in the national limelight because it really was a clear representation of all of the socioeconomic factors that were impacting communities such as Chelsea that is largely Hispanic. It's the second most dense city in all of Massachusetts, and we created a very robust COVID testing service and supportive services around that.
Thanks, Kelly. And Remle, you want to bring us home?
Sure thing. Good afternoon. My name is Remle Newton-Dame. I am the Assistant Vice President for Healthcare Analytics in the Office of Ambulatory Care and Population Health at New York City Health and Hospitals. It's a real tongue twister at parties. And we are the biggest safety net hospital system in the country. We serve more than 1 million patients every year. And in the spring of 2020, we were the epicenter of the COVID-19 outbreak in the United States. And we saw incredible casualties as a result of that in neighborhoods that we serve. And then all of the rippling effects from that and from this year, both in the COVID space and in the related sequelae parallel pandemic space. So it's been a big year in the safety net systems in addition to the COVID component. And then I also serve in an advisory capacity at the New York City Department of Health. So little slice of everything from testing and immunization on down to data.
Great. So let's dig in. I'm going to throw this one back to you, Remle. Given all of your work, can you give us an overview of where we are today as it relates to the vaccine rollout? What are the potential scenarios now, best case, worst case, and obviously recognizing that this is evolving real time. So would love to have you level set where we are on Thursday at noon.
Great. So it's evolving so real time that last night I went back and sort of rewrote my notes to myself because so many things have happened just this week, which is great. So let me start out with the good news on the supply side. So since Biden took office in January, weekly doses to states have increased from 8.6 million to 14 million. And this week they announced they would increase allotments weekly to 18 million. This is great news. And then additionally, they came out saying that they would promise enough vaccine for every adult by the end of May, which is audacious and exciting. Nationally, about 16% of Americans have received at least one shot. We are averaging 2 million doses a day now. And in New York City, where I work, we've administered more than 2 million doses to 1.3 million people. But I think it's really important right at the front to say that we know that those successes have been unevenly distributed. And the communities that bore the highest burden in terms of mortality per capita, which is African Americans and Latinos, have had the least representation within vaccination. And that's really important to peg at the very beginning of our conversation, because I think it's a theme that's going to run throughout the day. And it's one that every leader in healthcare needs to be thinking about actively. I am really hoping that Johnson & Johnson can help us change that picture. And this is sort of the best case scenario that I'm going to lay out here. So last weekend, the FDA authorized Johnson & Johnson for emergency use. On Tuesday, the really exciting thing in my week was that Biden announced the Merck partnership to dramatically increase the production and to roll it out at scale and to provide additional support in terms of logistics. That's huge and that's really exciting. Let me just unpack this a little bit because I think that there's kind of an elephant in the room, especially around the equity work, and I would say I'm so excited about it. So if you just look at the basic numbers that float out and about, and there's a lot of numbers in the COVID pandemic, it looks like Johnson & Johnson may not be as strong a vaccine as the mRNA vaccines, which is Moderna and Pfizer. But if you talk to an epidemiologist like me or my nerdly cousins all over the country, we will tell you that that is an apples to oranges comparison. So Johnson & Johnson was actually tested when there were already variants circulating. Moderna and Pfizer were tested before there was huge selective pressure on the virus and before the variants were really out and about. And that means that you really can't compare their performance. And we don't actually know how well Moderna and Pfizer perform at scale in a variant environment. So I think Johnson & Johnson is a strong vaccine. And I don't think that we have huge equity concerns at the current moment with the state of the current data. As we said, everything changes rapidly with thinking about delivering Johnson & Johnson specifically to populations. Obviously, there are still huge considerations about vaccine acceptance and acceptability, and we will have a continuously emerging picture because this data is changing in real time. So with that, we do know that Johnson & Johnson is 80% effective at preventing severe illness. So even though we know that the performance of definitely Johnson & Johnson and probably the mRNA vaccines is reduced, especially for some of the variants that have these modifications in spike proteins like B1351, which is where that stat comes from, that prevention of serious illness means that we won't overwhelm hospitals in the same way, and it means that deaths will be dramatically lower. So this is still a huge difference in terms of saving lives for the Johnson & Johnson vaccine. So within that context, what I'm really excited about is that Johnson & Johnson is going to make it much easier to reach high-risk populations. So it's a one dose, and it's much easier to store and transport. that means that logistics are really simplified. It means we can get it into the arms of people who can't travel much more easily, especially our homebound seniors who are very vulnerable. It also means that populations who have a fair amount of chaos in their lives, and it's going to be really difficult to get the second dose exactly 28 days later at the exact same site, can now just get one dose and be covered. Folks who are homeless come immediately to mind in that space. And it also makes logistics easier to set up pop-up sites at churches, community organizations, and workplaces themselves, which again, lowers the barrier to entry, lowers the time needed away from your normal activities in order to get the vaccine, and also increases the kind of trusted messenger benefits that we're really looking to exploit in order to directly address vaccine hesitancy and directly address these extreme disparities that we're seeing in vaccine rollout. Collectively, I think for me, this means that in the best case scenario, we're going to start to see a real easing of those early immunization rollout challenges like long lines and appointment bottlenecks. But in terms of the worst case scenario, if we just keep doing what we're doing, making everything digital, we're just going to see the disparities that we've already established, that we saw in healthcare before, that we saw in bias and algorithms before, that much of society seems to be organized around. We're going to see that replicate itself throughout the rollout. And so this is really the time that we need to act in a muscular way to combat the demand side of the equation in all of our communities. And I'll close out with the worst case. So this is a bit of I think Fauci said skunk at the picnic, and I personally loved that. This is a bit of a skunk at the picnic. So we are still in a state of emergency. Cases have decreased and are decreasing, but maybe are plateauing. But even in the decrease, the US had 472,000 new cases last week. And in the last 24 hours, we had 54,000 new cases and 21,000 new deaths. And that's just the ones we know about. So in addition to that, epidemiologists are really concerned about these new variants. B117, which came over from Great Britain, is hugely transmissible and looks like it has some additional mortality. B1351 and P1 both have changes in the spike protein that make the vaccines less effective in terms of blocking transmission. As mentioned, still we think very effective in terms of blocking death and severe outcomes. But that means that we may start to see kind of spring surges, if not nationwide, then in individual municipalities and states. And so I think we're still going to keep finding new variants as we expand genomic surveillance, as we really start looking. We just have the tip of the iceberg right now. So I guess my kind of take home here is I'm really still extremely hopeful that vaccines can bend the curve. And I think we've already maybe started to see that, especially on hospital surges and deaths, which is a big, big deal. But we still need to continue to promote the things that we know that stop transmission now, or the core four, right? Staying home when you're sick or exposed, washing hands, wearing a face mask, and socially distancing. So that's where I'll leave it with the kind of opener.
Thanks, Remle. Very helpful. Rachel, I know you are doing some of this in real time. Do you have anything to add?
I think, Remle, that was an amazing overview of where we're at and what we need to be focused on and what we might see moving forward. I'd love to touch a little bit on addressing the inequities that exist in our communities. When we first launched our mass vaccination sites at major stadium arenas, our goal was really to quickly stand up these vaccination sites and make services available so that we were putting vaccines in arms. And the demand has been so great that our schedules filled up very quickly. But when we began to look at the racial and ethnic background, gender, age, we noticed some real issues. And so as we moved into Boston proper and at a community athletic center in one of our hard hit areas where there was a tremendous amount of illness and death, we really recognized the need to take a very different approach. And so what I'd love to share with you is what we have done to move from a population served at roughly 85% white to getting down to 50% white and 50% people of color. And our work, and I'm fortunate to get to work directly with Michael Curry, who we'll get to introduce shortly, who is the president and CEO of the Mass League of Community Health Centers here in Massachusetts. We actually built relationships with community-based organizations from the Asian community, from the Black and African American communities to Latino and Latinx communities. And in working with them, we recognized exactly what Remle said, that if we use a digital first approach, we're truly not going to reach those who are most in need of vaccination, or it would be an incomplete approach. And so we've invested heavily in a few different areas. First is we made a decision that we don't just open our entire schedule publicly for the online registration and scheduling process. We only, with the state's support, we only open up 50% of our non-second dose appointments publicly. The rest of those appointments get filled by the Boston Public Health Commission, local community health centers, and then through personal referrals made by these various community organizations. And what we quickly saw was, as of this week, 44% of those vaccinated at this location are white, 16% Black and African American, 7% Asian, 5% other, 8% Hispanic or Latino, and the rest just refused to answer. So we've really moved that curve pretty considerably. And I would say that it's not just the mechanics of how you open or don't open a schedule. It's having canvassers out there putting information on people's doors out in the communities. It's having outreach workers knocking on doors and making phone calls to eligible populations, explaining what the vaccine can do, why it's important to get vaccinated, how we can make it accessible, whether it's transportation, a companion, somebody walking side by side with you. And then really, when you get to the door, not requiring someone to produce an ID or an insurance card if they don't have that available to them, not having a fully dressed security guard who might feel threatening to immigrant populations. It's really reducing the barriers all along the way to increase equity in our communities. So I'll stop there.
Thanks, Rachel. And it's a great time to welcome Michael to the discussion. Thanks so much for joining us. I'm going to ask you your thoughts on what's working, but would love to start off with a personal introduction, and also how is your organization working to support community health, vaccines, and social needs at this time?
Thank you, Ashley, and great to be on with you all. So just maybe by way of a little background, I am now the president and CEO of the Massachusetts League of Community Health Centers. That our organization represents 52 community health centers across the Commonwealth, over 1 million patients, operating out of over 300 practice sites. We love to share the data point that we serve 1 in 7 people in Massachusetts, and if you're in Boston, 1 in 2 people in the city of Boston. So we care for many of the populations that we're talking about today, particularly as we focus on equity, those that are the hot spots, those that are immigrant, that are Black and brown, that are, as I say, closest to the disease and should be closest to the vaccine. So as community health centers, we experienced a lot. I just want to recognize Rachel for her approach to the work that she's been doing with CIC. It is about collaboration. It is about bringing people to the table and having them engage in what makes sense from a culturally proficient way, from a way that's inviting to all communities. The fact that the Boston Black COVID Coalition is at the table working jointly with them is a model that we should have across the country. And I can tell you, talking to colleagues across the country, that is not the case. Some of these states that are getting vaccines in arms quickly are not necessarily doing it equitably. And I think we're trying to find a way to get there, and CIC, BMC's, Boston Medical Center's effort with Morningstar, with Bishop Borders, who's my bishop, and Mattapan Community Health Centers is another excellent example, in Russell Auditorium. So there's some shining examples of how to do this right. If we could just make sure that they get the vaccines, right? That's the biggest challenge in the moment, Rachel, is making sure that you have the doses, that health centers have the doses to put in arms. So I think, we as health centers, we're facing the infrastructure demands. As Rachel and others on the call know, there's a huge investment up front to meet the moment. When you think about repurposing existing space or bringing in the workforce, because you're already, from a health center perspective, we're still testing. and still trying to meet the demands of testing, as I think Remle mentioned, the increase in infection rates. Those are our patients. We're also contact tracing with Partners in Health. We're still seeing COVID, non-COVID care patients. And then now we're adding to that demand the vaccination effort. That's a huge feat for community providers, and public health agencies are in that mix as well. But we're meeting the moment. But we need the infrastructure and the upfront costs. And we're working with private foundations, Secretary Sutter's, the Baker administration, to meet those demands. Liability insurance for retired nurses and doctors that are coming back in droves to help. But there's some formality that has to be put in place to make sure that people are covered. The only thing I would add to that, Ashley, as we're in the moment, is maybe a point for Remle, as I joined when Remle was talking about the differences in the vaccines. Now, this is for me being a longtime civil rights activist, as well as a community health center person. I'm putting on my civil rights hat when I say what I'm about to say. There is an equity issue with the vaccines. And the way I'd like to do this is I ask doctors, if you had a choice, which vaccine would you get? And almost interestingly enough, many will say Moderna and Pfizer, even those in the mix of the conversation. It does not mean that J&J is less effective when we have the nuanced conversation. But if they had to say a drug that was effective for mild, severe, and death, people may make the choice that Moderna and Pfizer. Now, what we know is we don't want people forum shopping for a particular vaccine. It's not efficient. It is a nightmare if my mother walks in and says, I want Pfizer. But what I've said from an equity standpoint is everyone should have access to every drug, every vaccine. It is problematic if communities of color, because of convenience, only have access to one drug. That's a problem. That is inherently inequitable. We don't know what the nuances will be as more variants come and over the next few months, which drugs hold up under those variants. There's so much uncertainty in the science right now. It is effective and it is equitable to make sure if you're in Roxbury or Southside Chicago or Skokie, Illinois, or Newton, Massachusetts, which they should all have access to the vaccines that are on the market. So that's my only point on the equity piece. It is foreseeable, being a longtime civil rights activist, knowing that they will push the J&J to rural Massachusetts because of the convenience, to urban areas because of the convenience. And it may not be popular to make that point, but we've been here before with masks, where early in the pandemic, folks were saying, just put something over your face. And those of us who are activists were saying, no, we don't have access to KN95s and N95s. And Fauci, to his credit, well, I shouldn't say to his credit, was saying, no, just put something over your face. And we were saying, actually, that's not the science. The science is it doesn't cut down on your spread and it doesn't protect you. How do we make sure that folks walking down Blue Hill Avenue in Massachusetts have a surgical mask or something that protects them? And then you drive over to suburban neighborhoods and they have access to the masks that actually provide greater protection. Those are equity issues that we don't often want to deal with, but they're real.
But if you give me just 2 seconds to address that, I agree with every single point you made. This is a conversation we are having 6 ways to Friday. This is a conversation, the health department and H&H have both been very specifically equity focused because we've had a front row seat to a profoundly unfair and unfairly distributed burden of death in New York City and a profoundly unfair pandemic in New York City. And even just for a second, like even the way that we are creating categories, right? You have to be healthy enough to get to, in Massachusetts, originally 75. You have to be wealthy enough to get to 75 to even be eligible. And when you look at the age distribution by race ethnicity of this disease, morbidity looks dramatically different for Latinos than it does for white people in Newton, Massachusetts. So I agree entirely with everything that you said. I think what's really challenging from a policy perspective is that right now we are in this war, militarized language, but we are in this pinch point with these rising variants. And the more vaccines we can get to people, the faster we can get to people, the more lives we can save. And we know that some lives are much more vulnerable than others. And we know that there is just literally not enough vaccine, even for everybody who wants to get it. And so I think it's like it's a question of like, how do we do this? How do we do the right messaging? How do we equitable access is essential. It is essential, but it's not enough actually. just making sure that everybody can get access to the vaccine, you're not doing your job to actually create equity. You have to make sure that everybody has a viable, trusted path to the vaccine. And I think that that's the conversation that we're just not really having right now. So I agree, I misspoke when I said it's not an equity issue. What I was trying to say was, I don't know that we have enough science to know that there's truly a clear difference between these vaccines. That's a very different thing than saying there aren't going to be clear equity pathways that happen in this distribution, as they have happened with every step of this epidemic, that don't have huge impacts on communities of color. So yes, and.
Remle, I really appreciate you flagging that, like, the access question is critically important, but it is insufficient. The reporting as of last weekend was that 55% of Americans are ready for their injection. That leaves 45% of Americans who are not. And so, Abner, as you're working with communities, what are you seeing? One, their concerns, and number two, how can we reach people to educate and encourage them with the best science that we have and or other methods?
Sure. So thanks. And I'm really enjoying the discussion. What we are finding is that, and this has been true before the pandemic, when we were reaching out to people and trying to get them to come into clinics for more traditional kind of quality measures like immunizations for kids and well child visits and breast cancer screenings. If you want to build a trusted relationship with the patient or the plan member and get them to come into the clinic, you got to start with treating them like who they are matters. They're not just a number. They're not a file. They're not a premium payment. They are a person with a history, and they've got everybody has their own journey. Each of us has our own journey. It makes us who we are. And the social determinants of health, we do work a lot with Medicaid folks. Those SDOH issues also impact our lives in unique ways to make our challenges unique. So I'd say first and foremost, we're at a point where we need to start to treat people like who they are matters. And that means actually asking them what they think and having a two-way conversation with them. And we are in 2021 at a point where technologically we have the ability to do that. We can engage with people at scale. We do it. We're engaging with millions of Medicaid, and we're also doing other lines of business as well. Millions of plan members, and we're one powerful tool is text messaging. But if people prefer a phone call, we give them a phone call. But the key here is to treat them like who they are matters, to engage with them in a two-way conversation. It's not enough to just say, you need to get a vaccine and the site is over there, because that does not address the fact that for a significant number of people, they have questions, they have concerns, and we have the ability, and I think we have the obligation to address those concerns, because if we do not, the worst case scenario is that we're going to reinforce all of the existing health inequities, and we're not going to get the herd immunity anytime soon. We're going to be in 2022 because right now, because there's so little vaccine, the people who want it are lining up for it, and they're pounding on the door. I want the vaccine. I'm just saying that there's a second group of people who are unsure. They're not lining up. Even if there were vaccine available, they wouldn't be lining up because they have not been convinced to take it. And there's a third group who today are hard no. Not only not going to line up, they're like, I am not taking it. And so what we're saying, and we've been saying this with all of our partners and clients, is that now is the time to engage with whoever you're responsible for. If you're a health plan, it's your members. If you're a clinic, it's your patients. Ask them and do it in a way that's culturally and linguistically appropriate, and do it in a way that they can respond to you, because that'll start to give you a sense of who you need, who needs what kind of pathway, education, information pathway. Because if we don't treat people like they're individuals and engage them in that two-way, we're gonna be in 2022 having this conversation because we will have missed the opportunity.
Michael, are you guys doing any work in this area in terms of addressing vaccine hesitancy?
So Abner, I appreciate your comments, and I think we're all in that challenge. The town halls that I know Rachel and her team have hosted. We've done town halls. We started with our providers because we're seeing the same hesitancy among providers. When hospitals or health centers, 30, 40, 50% of your provider community could say, no, I'm not ready to take it. And it plays out along racial lines, right? You're Cape Verdean, you're Haitian, you're native-born Black Americans, descendants of Southerners. We saw that across our system, and we're seeing over the last month that number change. So it goes back to the Museum of Science poll that the Mass League did a few months ago with Mass Inc. It shocked us. It said 80% said they'll take it at some point. That was different than the summer of 2020 that said 50% said no. The reality is people want to wait to see what happens to you, Ashley, before they take it, right? They want to see what happens to somebody else, that you survive, that you don't get, gravely ill, and people are waiting, and that's a good sign. And we saw that play out with our providers. We're now seeing health centers reach 70, 80% of uptake of their provider community, and we'll see that number even grow over the next month. That same theme will play out with the broader community. We've been approaching it this way. Maybe this is because of the role that I have in my civil rights background. Embracing the truth first. And that's J. Marion Sims and his experimentation on slaves. That's Tuskegee syphilis. That is Institute of Medicine's unequal treatment that validated that Black and brown folks have a reason to distrust our healthcare system. Once we acknowledge that truth, and Abner, I don't know if that's 10%, 20%, 40% who don't trust because they know that history, or as I say, Rachel's, their mother held their hand tight through a really bad neighborhood and you just knew that that neighborhood was bad. That's how our healthcare system works too. People say, don't do that clinical trial because those folks are experimenting on you, or don't go to that hospital, or they don't treat you right here. Whatever those stories are and those experiences are, it's created a distrust in our healthcare system that we now, in this racial reckoning we're in, can acknowledge, validate, and then say, okay, now we want to introduce you to Dr. Corbett, the young African-American woman who was on the team to discover the vaccine. We want to introduce you to the amazing Black doctors and brown doctors who've been at the table to roll this out, and then it will bring the confidence. But we got to do that in a way, quite frankly, that if you have people of color at the table, like we do now, like myself and Abner and others, you can force that sort of reconciliation and then that conversation that will lead to trust.
Thanks. One of the things that also stands out to me very clearly, given our work, is, the vaccine is one path back to normalcy, but these inequities were not created in the pandemic. These have been here, and to some extent, we're just shining a light on truly systemic problems around access, not just in healthcare. And so even in the last week, our work in Chelsea, while patients are waiting for their test or, and the follow-up for the vaccine, we literally just connect them to what type of support could you need. And so instead of having this assessment, which is typically our SDOH, can you feed yourself? We instead just say, would you like connected to a food assistance or a meal delivery? What is shocking is the response is 40 to 48% of these patients are saying that they have social needs. And so Kelly, as you're thinking about your work in the Chelsea community, what other needs are really popping up as it relates to people navigating not just the virus, but life under this pandemic? I think you're muted.
Thank you. I've been so engaged in this conversation. Again, I'm so glad you're taping it because I think I'm going to be listening to it for a very long time. So thank you. I just want to, before I answer that question directly, Ashley, I have been doing a lot of reading. I partner with a nurse leader who's actually in a master's program, and she sent me a series of articles about this term syndemic, and I had never known what exactly that meant. And it's just to, give a quick definition for people that might not know, it's this, the intersection of disease concentration and disease intersection. And I think back to, I remember the first, month of the COVID epidemic, and people were calling it the great equalizer. Do you remember that? And I remember reading it in the local paper and seeing all these different articles. And I thought, boy, do they have this wrong. It's not the great equalizer. This is going to enhance and hopefully shine a light on the significant and systematic issues that are relevant and present in our healthcare system. And within, I would say, maybe about 2 months from when things really started to escalate, you didn't talk about the great equalizer anymore, or there wasn't that in the public media. Because I think very quickly, systems and public health communities and et cetera realized that it wasn't about the great equalizer, that if anything, and I've heard this quote, that the default lines became even more dramatic. And we saw this in Chelsea when we first started to open up, when we opened our COVID tent, we were advised that we needed to follow what the practice was for testing in the Longwood medical area. And it took a huge amount of advocacy by municipalities and other community organizations to help move that, to say, no, that's not going to work in Chelsea, Massachusetts. We need to open it up to everybody. You don't need to be a patient of this place or of this organization. We will test everybody. And once we did that, I think our volume literally increased over a period of a week of 100% a day. And between November 1st and January 1st, we tested almost 21,000 people. We're open 6 days a week, and it was just unbelievable. So now I wanted to provide that as a context. What we have seen is, and I am referencing this because I have the opportunity to do some other things in my current role. And one of that is I run 3 outpatient physical and occupational therapy services. And at every staff meeting and at every patient case meeting, we usually run a weekly review where our groups of clinicians will discuss either challenging cases or an interesting case or bring that forward. I would say at least 50% of those cases, we can connect the dots to this patient had COVID. And so I'm not a clinician. I can only speak to what I hear and what I listen to, that we are seeing so much of a direct health impact on many, not all, but on many people that have had COVID, whether that's continued deconditioning, ongoing respiratory or pulmonary issues, sustained musculoskeletal weakness, gait problems. And about 3 weeks ago, we considered looking at accumulating data so we can do a retrospective review. And I'm quite certain that we're putting that into place, and I am quite certain that we will see those fault lines. I am quite certain that it will be at least 60% of the cases that we review will be a reflection of people of color. And I don't have the answers as to how we I guess I'll say it this way. I think that going forward, one of the things that I think is so invaluable, and I've been so honored to be able to partner with really key researchers, is that there's a piece of this, as everybody has talked about, this level of distrust. And I can say that as a woman, I even feel that level of distrust in terms of there's so much in the media about how women are treated differently in terms of being a receiver or recipient of healthcare. And one of the ways that we can help respond to that truth is to look at how organizations proceed with research and to be more inclusive. And that, I think, oftentimes gets missed in the discussion. I will say that I'm so proud that Beth Israel Deaconess ran a study to compare saliva sample to a PCR test, and the only site that was a part of that was was in Chelsea. I say with great pride that Dr. Catherine Stevenson, a world-renowned scientist, we are running a study for Regeneron. It's a medication to help with the spread of this horrible disease to household contacts. They tried to get it up and running in Boston for months. They couldn't. Chelsea's the only site that research is running. And that is a critical component of making progress to hopefully close those default lines.
I really appreciate your comments and, calling out that there is secondary implications for people who have gotten COVID. Some of you may know, I lost my uncle just over a week ago, who spent the last year as a stroke survivor and diabetic in a 600 square foot senior living facility in his apartment. And yes, I am confident that he didn't get COVID. However, the way we've been living over the last year will have long-term health inequity issues for decades. And when we talk to clients, we're really trying to help reframe, yes, there's a triage moment, but we need to look at this as if this is a 9/11 first responders problem that will be ongoing for the next decades. And so, Remle, I'm interested, what are you seeing in New York, and how can we, really address these parallel pandemics with successful models?
Thank you. Yeah, I think that that's really essential. I think one of the things, listen, I'm an epidemiologist, I'm a data nerd and analytics person. I get into the science and it's an exciting slice of the conversation. But the sexy stuff comes and goes, and the stuff like diabetes and hypertension that kill an extraordinary number of Americans every year and make an extraordinary larger number have much more challenging lives than they need to have, is something that has been going on before COVID, but is definitely exacerbated by COVID. And so, we're anecdotally seeing huge impacts in the patient populations, something like a 10% decrease in diabetes control and 20% decrease in blood pressure control among hypertensive patients this year. That's going from like January. And I'm not citing hard stats because they're not published, et cetera, but something in that ballpark. I am willing to bet that if you look into a lot of systems like ours, you would see something similar happening. Patients have been afraid to come in and get care. They've been afraid to get COVID. They've been potentially losing their insurance because there's been a ton of job churn, and a lot of people lost their insurance. We were already a 35% uninsured, 35% Medicaid system, but I'm sure that breakdown has changed this year. And then I think, if we're looking at structural root causes, housing insecurity has been a huge issue in urban centers, and especially in New York for the entire decade, if not longer, obviously longer, but COVID put that on steroids. And we have seen just an enormous impact from housing insecurity. And there are those fantastic landmark studies out of HUD that said that when you gave housing unstable and homeless people housing, they were able to get their HIV levels down to undetectable because they could focus on medication regimens when they didn't need to worry about where they were going to sleep. And I'm talking housing insecurity writ large. I'm talking about couch surfing, frequent moves. I think we look at homelessness just as you showed up in a shelter or the street. That's a really small percentage, and that leaves out women and families a lot. And cultures that have a more adaptive response to housing insecurity, but where it's still placing enormous pressure on people. And we saw that in the outbreak that happened in Queens, where you had a lot of co-location with one apartment for a large number of people. And in New York State, I just saw, a fantastic study that kind of quantified this. So they looked in 2020, 6% of white households said that they were behind on their rent, 22% of Latinx and 51% of Black households were. And you see really similar studies if you look at the amount of like fungible income that people have. So I think if we as a health system want to address diabetes and hypertension, we need to address housing insecurity. So one of the things that Health and Hospitals does is co-located legal services, free legal services that will talk to you about what you need, that will treat you as an individual so that you can come in and lay out what it is that you want help on, whether it's immigration or domestic stuff or access to benefits or employment disputes or housing insecurity and pausing on evictions because the pause on eviction moratoriums was lifted and blah, 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 blah. It's a whole route that we could go down and have a fun conversation about. And I think if we're not helping patients solve their own structural inequality, their own structural determinants of health, inequalities are a much larger thing, and that's our responsibility, not theirs. But then I don't think that patients are going to be able to focus on the things that their doctor would ask them to focus on in the clinical encounter. A couple other things that I think are really important models in this space. There was already a really lovely model developing around stuff. I think it's called 3-2-1 impact around interrupting intergenerational trauma. I think housing insecurity and a sudden increasing housing insecurity is definitely an intergenerational trauma source and a thing that may put families into risk of foster care, risk of family disruption. And so we're looking at starting a care dyad between mom and kid through age 5 for every mom and kid that come through our system, and doing maternal screenings at the pediatric visits, connecting them to service at the pediatric visits, even though it's mom who needs the services or family who needs the services, because for some reason we've been treating them as distinct, but kids' health is really rooted in familial stability and mom getting what she needs to be successful, which she's not in many cases, and especially right now. So I think really thinking about that social determinants work, and you'd asked us sort of like, what are new models? I don't think we actually need new models on here. I think we need to pay for the models that we know work. These are not new concepts. They're not new problems. They're just bigger now.
Thank you. Michael, I'd love your perspective on this.
Yeah, so one, I need to find a way to recruit Remle to Massachusetts because we need you here. But I would say, I think one, Kelly's spot on with the fact that we need to start collecting data and recognizing that this disease has longer term implications on the communities that we care about. And we're seeing that play out. And anecdotally, I'm getting that information from our patients through our health centers as well. Remle, it's so important that, I think about Jack Geiger in this moment, the founder of the health center movement in 1965 when he launched health centers. He understood it was not all about what we do with patients when they walk through our doors. It was also about what drove them into our doors sick. Way before we got to understanding social determinants of health, that term, he understood it was about the water access that you have, the clean water, that it was also about food and housing insecurity. So the reality is, I'm concerned as I think about this moment we're in. I call it an economic tsunami, but it's a public health tsunami as well. And the economic tsunami is we know that students are not attached to school, right? Some kids have disappeared. We know that some kids aren't getting the academic rigor. We already had an achievement gap before this pandemic started on every level. Then we also talk about the wealth gap, the opportunity gap, the income gap. Go down a list of all the disadvantages that we've all been working hard to overcome, the disparities, the gaps. And now a pandemic comes. All of that gets worsened. So the person who had cancer who didn't get their treatment because they were afraid to go to the hospital or afraid to see a provider. We have to, and I'm thankful for Remle and researchers that are already starting to collect this data. I probably only want to add one other thing. The Harvard Chan School has also launched a community coalition, a community group that's involved in research. And I think it's an excellent model for the rest of the country where they pull people like me and others together. And they're saying to researchers, come before this community panel to present your project, your research before you ever move on. And it gives us a chance to be engaged in the project to make sure there's efficacy, there's safety, there's inclusion, there's diversity in the process. I hope that whatever materializes from that work here in Massachusetts, it becomes a huge model for the rest of the country.
I really appreciate that. And we see that in our data. So patients are 4 times more likely to be asking for financial assistance now than they were a year ago. They're 3 times more likely to be seeking behavioral health or emotional support. Most tragically, to specific Massachusetts operations, we saw domestic violence spike into the top 3 most requested categories Thanksgiving week. And so this paternalistic model that everything has to go through a person in a health center, everybody's home with their families eating turkey, and people need support in real time. And so Abner, I'm really interested to hear, are you seeing this as well? And are there any things that you think we can learn from or replicate to Remle's model to be able to address some of these issues?
I'm sure I just make two suggestions for going forward. One is we need to collect race, ethnicity, and language data. It's just a scandal to me that we are in 2021 and we're not doing that. We didn't do it for testing. And now with the vaccine, I think the CDC released some data. Only 17 states are reporting to the CDC race, ethnicity, and language data. What that means is that we don't know. We can't figure out a baseline. We don't know where we need to invest more. What we all know is that there are disparities and inequities, but if you can't put a metric to it, if we can't quantify it, it means that we're not going to be able to solve it. And so we have got to, I don't know how else to say it, that we have got to get the federal government and the states to collect this, to insist that this data be collected, and not just about the vaccine. It's crazy that only 17 states are reporting. We need to collect this data across all of healthcare. We can't go back to the healthcare system we had where we weren't collecting it. We didn't have a baseline. You can't hold anybody accountable. You don't know where to invest. You don't know what's working. It's just a screwed up situation when you don't collect that data. So that's the first point I'd make. We need to collect that data. We need to start now. The second point is that I think and I saw an article yesterday that Andy Slavitt, who works at the White House now, has finally has organized an effort to get health plans involved in this effort. Health plans are a big part of our healthcare system. However you feel about them, they need to be a partner in this. And for the first time, to the administration's credit, Andy Slavitt and the Biden administration, they've gotten the plans to agree to come together and help with getting vulnerable 65 and older populations vaccinated. Well, two things. One, that's great, and it's finally happened, and they really deserve credit. But we need to make sure that they don't limit that to 65 and older. The plans have a huge role, especially Medicaid managed care plans, in the rest of their member population. And what the plans need to do, I think, my suggestion is, and we've been suggesting this to our plan partners, survey your members. You're in a position to ask them, it's a very easy question. Are you ready to get the vaccine? Yes, maybe, no. And then we can develop strategies to address those different groups of people. Going forward, if we don't start to change the way we engage, we run the danger of falling back to the old system pre-pandemic that didn't work. We know it didn't work. And if we let ourselves slip back and end up embracing that old health system, the pre-pandemic system, then shame on us, because we know better and we know we can do better. And so we've got to figure out a way to align and get everybody rowing in the same direction so that post-pandemic, we start to have a healthcare system that really works for everyone.
Rachel, Kelly, Michael, I assume this won't be our one and only round of vaccinations. And so assuming that we can design for how we're going to do boosters and how we can take advantage of the time, whether it's when people are sitting for observations or how they're going to get into the process, are there any other ideas or concepts that you think that might work to be able to leverage that touch point to address some of these broader needs, whether it's deferred access to care or sorry, Kelly, you want to go first?
Yeah, and we piloted this. We are the only community health center in BID that offers a 2-week flu clinic. And so we had, one huge tent on one side testing 500 people a day. And then we had 2 smaller tents on the other side of my building conducting the flu clinic. And what we thought was exactly as Rachel, Remle, Michael have talked about is the idea around that health conditions got worse. And so what we thought about was, from a population management perspective, is to really efficiently and effectively use our resources. So we estimated that we would have about 1,500 patients come through in that 2-week time period. And what we did is we have a clinical pharmacist that is here at the health center on a part-time basis. We leveraged that clinical pharmacist so that he could be here full-time. And so as people were either checking in or waiting in line, we had done we had pulled some data to say, listen, if they're diabetic and they haven't had 2 A1C measurements, we'll pull them out of line for 5 minutes. It's a value add to them, right? Because they'd be waiting in line anyways. Leverage that. Or somebody has hypertension, and I'm focusing on those two conditions because I think that that is a clear, those diseases clearly reflect on racial disparities. And so we pulled folks in for a blood pressure monitoring check. And if it was high, or depending on the result, we had the pharmacist quickly email the PCP and either then set up the appropriate next step. And we had, I think it was 1,300 people, of which 500 people we had that touch point. And I think about that, it was easy. It wasn't a heavy lift. We thought about it in an efficient and effective manner. And quite frankly, I think it helped continue what I hope is a view of the community around our health center, is that you're welcomed. We want to take care of you. We want to tuck you in. I always say that to staff. We want to tuck these patients in. And it was, instead of waiting outside for 10 minutes, come on in. We'll have the pharmacist check this out and we'll put you back in line. You won't lose your spot. It was brilliant. And I think that those are the types of solutions that we can easily come up with.
Wonderful. Michael, do you have any other things, services that might be worth flagging?
No, I thought Kelly was spot on. And I defer to Kelly, who's on the front lines of doing this work. So no, actually, I thought it was excellent.
So Rachel.
Well, yeah, I think that was exceptionally well stated, Kelly. I think one of the things that we're thinking a lot about as a private operator coming into the existing healthcare delivery system at a time where the health systems, the traditional health systems, whether it's community health centers, academic medical centers, primary care offices, are incredibly stretched to deliver services. If we go through another round after this in a year from now, where we're doing boosters or whenever that is, I think that there's still going to be a need for supplementary sites that are doing vaccination services or testing and otherwise. And what we've really been focused on doing is building a new relationship. Some of the leaders of the Black Boston COVID Coalition talk about building a new relationship between communities of color and the healthcare delivery system. And to do that, if we know that we're going to need these supplemental operational resources to do that, I think what we need to be thinking about is how do we integrate the work of community health centers, primary care offices, health systems together with these private operators, because we want it to be the communities serving the communities. If you have other groups coming in to help boost up these efforts and they look like me, I don't know that it will be as effective as if the operators look like the people and are the people in the community. And so one of the things that I just want to express to the audience is how important that we begin working now, not just for now, but for the future, to integrate those efforts and make sure that as we design our future booster clinics, ongoing testing, that we're doing it with the community, for the community, in a really trusting kind of way.
Rachel, I really appreciate that comment, and think that to the extent that we can be really hyper local in our solutions in the next phase of this work, and it's not just healthcare, right? All of these things play together, as Remle sort of really effectively highlighted. And so I think that one of the last questions was, what can we do as participants to amplify these points in our community? And we will send a follow-up based on this discussion, specifically back to the audience in terms of where can we go from here? Because it's great to be on a webinar, but if we can't actually move this forward and work together in these new models of care, I think it's all for naught. And so really grateful not only to the panelists today, but for all of the audience joining us and how you'll move this work forward. I think the good news is there's a lot of passionate, creative people, and getting everybody in the room together, I think, is the first step. So thank you so much to everyone for joining us, and we'll be back with you soon.
Thank you.
Thanks very much.